I just one more minute, Dr. T. I'll get you going.
Yeah, of course. Thank you.
All right, well, welcome to Thursday Internal Medicine Grand Rounds, Roy Benke. This is our last of the fall series of Grand Rounds. And so the same way that the Yankees had Mariano Rivera as their closer, we have Dr. Tabatabaian as our faculty closer. And so Dr. Farnaz Tabatabaian is an associate professor of medicine in the Division of Allergy and Immunology and also in general internal medicine. So Dr. Tabatabaian is a graduate of Wright State University where she got her chemistry Bachelor of Science, then continued on and got her master's with a thesis in immunology, very interesting, from Wright State before graduating from Northeast Ohio University School of Medicine. She is a graduate from the Wexner Medical Center at the Ohio State University for internal medicine, where she is where she continues ABIM board certified, and of course came here to Tampa to do her fellowship in allergy immunology at Johns Hopkins All Children's and USF College Morsani College of Medicine, and she is board certified in allergy and immunology. Hard to believe that she joined our faculty over 8 years ago, but became our program director in allergy and immunology this past July. I can state as vice chair of education, it is my pleasure to mentor her, and she has been an absolutely outstanding rookie program director, one of our many young program directors, which really just absolutely have really put a lot of vigor into our already outstanding academic program. So it is an honor to introduce her talk. For Dr. Tabatabaian's talk of mast cell biology and the role in indolent systemic mastocytosis. Dr. Tabatabaian, welcome, and thank you for everything you're doing with our fellowship and with all of our internal medicine residents and fellows, that you are a fantastic mentor. Take it away.
Thank you, Dr. Lozama, for that kind introduction. So just some few disclosures. I am on an advisory board for multiple industries. I would like to go through this lecture by kind of giving you a little bit of background on mast cell biology. And the reason for that is that I think that everything in medicine, no matter what you do, be it rheumatology or oncology, everything starts with the actual immunology of normal, and then when that abnormal goes array, then you get pathology and disease. So today I'm going to focus on mast cell biology with you guys a little bit. And then I would like to talk to you guys about presentation, diagnosis, and treatment of indolent systemic mastocytosis, and some of the new therapeutics that are kind of coming down the pipeline, and one of which recently got FDA approved for this disease state back in June of 2023. So kind of an overview, I'm going to give you 3 clinical scenarios, and I'm just going to read these for you guys really quickly. One is a 27-year-old Hispanic male presents to the office after having a progressive rash spreading on his back and now on his inner thighs. He doesn't have any abdominal symptoms. He doesn't have any flushing, no really history of allergic reactions. The second patient that might walk into your office or even mine in the past year is a 49-year-old Caucasian woman with no medical history, presents with multi-year history of persistent periodic chronic abdominal cramping and diarrhea with occasional mucus-filled stools without any sort of significant weight changes, and denies any sort of nausea, vomiting, flushing, or skin rashes. Physical exam is unremarkable. And then the third case that you might see in your office is a 52-year-old male with a history of coronary disease, hypertension, hyperlipidemia, and is presenting after being found down by his son on a farm, was life flighted into the hospital in the ICU for several days. He's had 2 former occasions after being stung by a wasp and a honeybee with a severe allergic reaction. He's a farmer and cannot avoid Hymenoptera exposure. So all the 3 of these patients are patients that I've seen within the last year or something similar to their history. And it's not to say that, you know, if you see these patients, because their histories are so common, and you might see these patients all the time with similar type of symptomology or presentation, that they all have, you know, some sort of mast cell disease, because this is the talk that we're talking about it. But it is something that you should think about as a differential diagnosis as you see patients with some of these presentations. So let's talk about mast cell biology. Mast cells were described by Paul Ehrlich in 1879. In fact, when he actually described them, because of all the stuff that was inside them, he initially named them mastzellus. Later on, they were found that they are derived from the bone marrow, and then depending on where they go, they have various maturation and how they end up looking like at the end. As you can see by the EM in this picture, these guys are incredibly intricate with a lot of intracellular granules inside of them, and within those granules and crystals they have mediators, which are either preformed or immediately made upon exposure of the clinical presentation or situation that they might be in. You have mast cells that are scroll appearing, you know, and that's kind of in this bottom corner, which are predominantly tryptase based and have a lot of tryptase inside of them. And then you have mast cells that are lattice appearing granules, which are tryptase and kinase within them. And depending on where they originate from, they have extensive heterogeneous component to them, and where they're coming from, either the fetal liver or the bone marrow, it really kind of defines as to how they differentiate in tissue. So from the bone marrow, you have these uncommitted pluripotent progenitor cells that end up in the bloodstream, and as they're progressing through the bloodstream, they transmigrate into tissue, and depending if they're within serosal tissues or mucosal tissues, it really defines as to what's inside of the granules and so forth. And that really identifies their function and what they end up doing later on and the purpose of them being there. In general, when you look at the immune system, anytime you have an immune cell that is, you know, coming from the bone marrow and then has to transmigrate into tissue, in order for it to further mature, you have to have cell survival signals. That's the case for pretty much every immune cell that you can talk about. And in particular, with regards to mast cells, you know, they transmigrate into a tissue, and it's the fibroblasts in that skin or connective tissue that secretes a specific cell survival signal for these guys to further differentiate and in becoming into mature mast cells. And I think that this is might seem something that, you know, why do I really need to know this as a physician that takes care of patients in the outpatient setting? And I think it is becoming more and more pertinent. We understand the underlying immunology, because our therapeutics are becoming a lot more specific and targeted, and therefore understanding what we're targeting is going to be allowing you to be a better clinician. So in this particular case, we have something called stem cell factor that binds to a receptor on mast cells, which is called KIT, and then that causes for you to have further intracellular activation, as seen in this picture, and you have you know, a bunch of transcription factors that come together, and it causes for the growth of these cells, the differentiation, the cell survival, and even their ability to undergo chemotaxis, which means basically moving around, and then cytokine production. So the presence of that stem cell factor brings that KIT receptor together and really allows for these immune cells to have cell survival and differentiate. These immune cells are incredibly complicated. I think that, in general, when we talked about mast cells, it's specifically talked about with regards to type 1 hypersensitivity reaction. And what I mean by that is where you have an allergen that has a specific IgE, and it binds to the IgE receptor and causes for degranulation. And that's definitely one of the most common and understood mechanism by which these cells get activated. However, over the last few years, we have identified a lot of receptors on these immune cells that actually can be activated, contributing to degranulation of the preformed mediators that are within these cells. And effectively, like some of the things that you might have even seen at bedside is that, sometimes we talk about red man syndrome. And, red man syndrome is when you have like vancomycin running too quickly, and it can cause for patients to have flushing and itching. And that is not an IgE-mediated reaction where like an IgE binds to an FcF Actually, it's an activation of a receptor, which is called MRGPXR2. And that's a G-coupled protein receptor. And just activation of that receptor causes, again, degranulation of this immune cell, which is the end product looks very much like a IgE-mediated reaction. But if you look, these cells also have all kinds of other receptors on them, including complement receptors, TLR, and then you have Ig receptor and leukotriene receptors. So it just shows you that this is an immune cell that interacts with multiple other immune cells, including the complement pathway, including the innate immune pathway, where you have pattern recognition with regards to pathogens and so forth, and then also with your humoral pathway. As a byproduct of the activation of these cells, you have mediators that contribute to basically some of the signs and symptoms that we see in patients that we might have some sort of mast cell disease or mastocytosis. One of these mediators is tryptase, and I think that understanding tryptase is really important for us now clinically, because this is something that can be measured at bedside. So tryptase is essentially a tyrosine protein that's synthesized in the endoplasmic reticulum. You have three different tryptases, which consist of the alpha, beta, gamma. And so if I were to measure the tryptase in the blood of anybody, you would have some degree of tryptase there. And that is essentially the alpha, beta that is secreted from the cells at all times. You have a third subunit of tryptase that actually is then stored in secretory granules. And then upon an active stimulation of these mast cells, that component gets dumped out. And so then you have an elevated tryptase following a mast cell activation event. And that's what we measure. Usually if someone has an allergic reaction, it's within the first 90 minutes. If you measure a tryptase, then and it's elevated, then it can be very correlated with an anaphylactic reaction. Other mediators that these guys have include histamine, proteoglycans, proteases, heparin, and then preformed cytokines, as well as secreted granules, which consist of prostaglandin and leukotrienes. And if you look, the fact that it has all of these different mediators that can be secreted, it contributes to vascular permeability, it contributes to regulation of vascular tone, and even to angiogenesis and repair. So at baseline, their function is essentially cell recruitment, regulation of tone, permeability, and even repair. Other clinically relevant mediators that we can measure at bedside include histamine, and typically you can measure this in forms of N-methylhistamine in the urine, as well as prostaglandin, which can be measured within at bedside in the urine as well. So these are all of the components that can be dumped upon activation of these immune cells. So what happens when you have disease. So mastocytosis is essentially a clonal mast cell disorder. And what that means is that you have a mutation in that KIT receptor where, you needed that to have that KIT receptor with the stem cell factor to be activated. But this mutation causes for you to have a continuous activation of this immune cell now, where it will not turn off. And this is a dysregulated survival, cell growth, and differentiation of this immune cell now. As far as the prevalence of mastocytosis, is 1 in 60,000 in the US and 1 in 60,000 in the United States, and the incidence is a 1 in 100,000. It can happen in both adults and children, a 1-to-1 ratio to 1-to-3 ratio in male to female. You can have a congenital component. Majority of kids usually have a cutaneous one that will regress later on in puberty, but most adults are typically diagnosed between the age of 40 and 60. And essentially, the component that we see with patients is that they have a mutation in KIT, and that mutation causes for you to have overactivation of that immune cell, which then causes for you to have disease. The WHO criteria for mastocytosis, you have cutaneous and systemic. Cutaneous is typically described as urticaria pigmentosa or diffuse cutaneous mastocytosis or mastocytosis of the skin. And then systemic, we have indolent systemic mastocytosis, smoldering systemic mastocytosis, systemic with associated clonal hematological disorders, aggressive mast cell leukemia, and sarcoma. And for the purpose of this talk, I'm going to be focusing on the indolent aspect of this disease because the smoldering and beyond is really managed by the hematology and oncology world, and there are therapeutics that can target it better, whereas the indolent has been something that has really not had a whole lot besides symptom control. In general, as far as indolent goes, this disease has a progression of potential progression to becoming aggressive. Majority of patients that have indolent systemic mastocytosis tend to stay there. However, if you have any sort of presence of organomegaly, that's when you have, alarm signs that this is progressing to a more aggressive or a leukemia or sarcoma type of picture. But within that indolent realm, you have all kinds of symptoms, which consist of your skin, your GI, your cardiovascular, your neurological, a lot of constitutional and bone, and even anaphylaxis. And so this is a multi-organ disease with multi-symptoms because of this overactivation, or as Paul Ehrlich said, you have now these mastzillas that are active everywhere. So going back to our clinical scenario, we talked about this 52-year-old male with coronary disease, hypertension, hyperlipidemia, that's been found by his son now one time and even life-flighted into the ICU. And he reports having 2 severe allergic reactions in the past after being stung by a Hymenoptera. So essentially, is what this gentleman is undergoing. It sounds like, he's undergoing anaphylactic reactions that have been fairly life-threatening. And so this is a IgE-mediated reaction where you have a first exposure and then sensitization, and that produces IgE towards that allergen and essentially causes for you to have binding to the IgE receptor on the mast cell and degranulation. So if you have patients that already have fairly activated, dysregulated immune cells, you can imagine that the reactions that patients can have with mastocytosis can be very severe, very life-threatening, and scary. Oftentimes, you can see triggers that exacerbate these things, including alcohol, infection, and even iodinated contrast. But insect stings is one that, is really unique, right? So we do live in Florida, and, because of that nature that we live in, we do have various different venom that is out there, including Hymenoptera. So we have wasps, we have yellow jackets, we have hornets, bees, so forth. So if a patient presents with an anaphylactic reaction post-sting, this is something that maybe you should consider getting a consult from Allergy and Immunology and further evaluation. So then we have the second scenario that we talked about, which is our 27-year-old Hispanic male who presents to the office after having a progressive rash spreading on his back and now on his inner thigh. He has no abdominal symptoms, no flushing, no history of allergic reaction. Does anybody know what this rash is?
Toxoplasma?
Okay. Why do you say that? It's red, it's macular looking. And if you look in this particular picture, you see even a little bit of dermatographia. Anybody else have any other guesses?
Dr. Casali? Or Dr. Pepper?
Urticaria pigmentosa.
Yeah, urticaria pigmentosa. So this is one of the most common rashes that you see in indolent systemic mastocytosis patients. Oftentimes, these patients do have some sort of skin involvement. Urticaria pigmentosa can be seen in kids and adults, and oftentimes kids tend to outgrow it. It just goes away. But in an adult patient that it just presents, it is suspicious that you might have a systemic component to it, and does require further evaluation. And so if you look, this is some other pictures of how this might look. Urticaria pigmentosa spares the palms, the soles, the face, the scalp, but it has this red, tan, brownish look to it, and it has a particular, sign that you can actually, do at bedside, is that if you scratch the rash, it urticates, and you can see that on the side of this slide, where you see that there is like this flaring of the skin around it, and that is called a positive Derrier sign. This rash can be it doesn't have to be itchy. However, there are certain things that can make it pruritic, including just being out in the sun, having spicy food, or even stress. And in fact, the patient that was described earlier wasn't pruritic. However, every time he went to the beach and it was out in the sun, he felt like his skin was really itchy with the rash. And he actually thought even the sun was the thing that was making his rash come on. The third clinical case, and I think this is a very common patient that we all might see in our clinical practice, including in GIM or even in GI. And it's not to point out that every one of these patients has mastocytosis, but rather this is part of the differential of a patient that might present like this. So this is a 49-year-old Caucasian woman with really no medical history, but she's had this like persistent periodic abdominal pain and diarrhea, and even mucus-filled stools. Doesn't have anything else really that's remarkable, doesn't have an associated rash, however, has these symptoms. And mast cells actually play a really significant role in the GI. Normally, again, they're there for tissue repair and calling on other cells. However, when they're dysregulated and there are further being differentiated at a hyper level, then you have dumping of what's inside of them, which we talked about, the mediators. So of which include histamine, And that histamine component essentially contributes to, acid production, and essentially can be so overabundant that can even lead to peptic ulcer disease. You also have production of prostaglandins, which impacts the smooth muscles and increases intestinal motility, which then you would, the side effect of that would be diarrhea. And then you have the production of these histamine and serotonin and prostaglandins at the neuronal level, which you have at the nerve endings of your, and within the GI tract, which then contribute to increased visceral pain perception. So again, mast cells are present in the GI. And if you have a dysregulated mast cell, now you're having a bunch of dumping of stuff that actually can contribute to some of the things that we see in this disease. So 80% of these patients have significant GI symptoms. They do have associated diarrhea and pain. About up to 40% can have peptic ulcer disease, which is significant to know, and they can even have potential GI bleeding, although very uncommon. As far as the hypermotility aspect of it, and do these patients have any sort of malabsorption? There has been some reports that some of these patients do have malabsorption, but not that as much as you would think with the degree of symptoms that they're having. They also play a huge role in the bone. So physiologically, mast cells are there, and it's important for bone turnover. However, in osteoporosis, the secretion of histamine, TNF, and IL-6, which are again mediators in the mast cells, causes to have upregulation of osteoclast, which then contributes to bone resorption. And this is also has been seen in rheumatoid arthritis. And in a normal process, their function is to help with repair. They're there to help with repair and remodeling. However, when you have a dysregulated immune cell, again, then you have an overproduction of these mediators, which then contribute to disease and predisposition to osteoporosis. So these patients actually have increased risk of osteoporosis, leading to pathologic fractures and even vertebral fractures in the back. Oftentimes, patients have neuropsychiatric components, and where they describe memory impairment, decreased attention span, irritability, and then overall, just brain fog is something that you might see. And some of the thought process of this is the increased overproduction of histamine. So how do you diagnose this disease? And I think that this has been something that has really changed maybe over the last year or 2 years or so, because now we have therapeutics that are much more targeted, potentially coming down the pipeline, and one that is FDA approved. But the diagnosis of systemic mastocytosis is really, to try to get tissue. And tissue is always the issue in medicine. In particular, getting tissue from the bone marrow is helpful, but you can also have extracutaneous organs, and oftentimes this is something that is done within the GI realm. So some of our GI colleagues do biopsies when they do endoscopies and colonoscopies, really colonoscopies. So what is required is, and this is based on the WHO criteria, you have to have 1 major and 1 minor, or 3 minors. And if it's really the presence of greater than 15 mast cells that are aggregates or clumped together. And I think that's the key thing that really needs to be emphasized when you're looking at these slides, is that oftentimes we have mast cells in different parts of our bodies, but it's the fact that they're aggregated together is the thing that makes it a dense infiltrates that makes it stand out. The minor criteria consist of if they are abnormal looking, so if they're spindle shaped, if they don't have, if they're hypogranulated, they don't have a great looking nucleus. Staining for c-KIT is obviously really helpful and important. Staining for CD2 and CD25 expression on mast cells, and then the presence of a tryptase greater than 20. So one of the things that, at least within the realm of my specialty, oftentimes if you get a baseline tryptase and it's not that elevated, then you automatically would put a halt to that and say it's less likely to be mastocytosis. But that's really not the case, because that's just one minor criteria, and the patient might have, other components that would be consistent with this disease state. And so now I think that the exciting part of our clinical practice is that we have a high sensitivity way of analyzing for a KIT mutation in the blood. We've always been able to evaluate for c-KIT in the blood, but the assay was not that great. So even if you had a high suspicion, really moving on to a tissue biopsy was recommended. But now we have this high sensitivity test, which is a really great tool. However, even with that, if our suspicion is fairly high for this disease state, biopsy is still a gold standard. So why do all this stuff? If you look at this cell survival chart, and you look, I know it's hard for everyone to see, but essentially, the expected U.S. survival is that blue line, and then for indolent systemic mastocytosis is this red line. And if you look, this is a disease that doesn't impact mortality. It does not cause for patients to die sooner. However, it's a disease that impacts quality of life. And the reason that I bring that up is that if you think about the wide variety of these immune cells and where they're located and how they can impact different organs, oftentimes these patients are on multiple drugs because they have symptoms like pruritus, flushing, abdominal pain, headache, recurrent hypotension, osteoporosis, and just managing those symptoms. On average, patients can be on anywhere between 4 to 9 medications a day. And essentially, for all these different disease states, you put them on things that target the mediators that these guys are dumping. So, histamine is one, so you put them on antihistamine. Essentially, leukotriene is one, you put them on leukotriene inhibitors. Prostaglandins is a mediator, so you put them on something like a non-steroid anti-inflammatory drug like aspirin. If they have recurrent anaphylaxis, you prescribe epinephrine and hope that they don't keep anaphylaxing on you. And then for us, within the realm of AI, allergy immunology, we have so many disease states that target Th2 immunology, and so we have a lot of biologics like Xolair and Dupixent, and so some of those drugs are also utilized at bedside off-label, although not first-line or second-line therapeutics. And obviously, if you have osteoporosis, then putting them on bisphosphonates and then further drugs if they can't tolerate it because they have peptic ulcer disease. So all of this stuff is something that's been ongoing for a long time. And, the therapeutics has been really the same until, the last 2-3 years, where there has been a lot of research done on really the aggressive aspect of mastocytosis. And now with that has trickled into indolent systemic mastocytosis. And now we have an FDA-approved drug, which is a tyrosine kinase inhibitor that potentially can help with this disease. I'm going to talk to you guys a little bit about tyrosine kinase inhibitors real quick. Essentially, when we talk about tyrosine kinase inhibitors, we have protein kinases that are in our bodies. And essentially, it's the phosphorylation of these kinases that causes for us to have different things that happen, like proliferation, differentiation, cell death, cell cycle, metabolism. If you have a abnormal protein tyrosine kinase that has gone haywire, then that can essentially potentially be a target for a kinase inhibitor. And essentially, when you think about mastocytosis, we talked about in order for you to have cell survival signals, you have to have this stem cell factor that binds to this KIT receptor. And if this KIT receptor has gone haywire, as you see in mastocytosis, then you have this overproduction of this mast cell and its associated mediators, which then leads to disease, which then is essentially indolent systemic mastocytosis, or if it's progressing to becoming the aggressive forms of mastocytosis. So how can you prevent it? And so we have now tyrosine kinase inhibitors that are very targeted for this KIT mutation. And, we've had imatinib and midazolam in the past, but in particular, avapritinib is one that targets this exon 17. It has high efficacy and high specificity for this KIT. And by blocking that, then what happens is that you turn off this continuous differentiation and maturation of these aberrant cells. And that hopefully will lead to improvement into overall symptoms. There's another drug that is also in clinical trials, and it's called bezuclastinib, and it's very similar to avapritinib and actually has a very similar molecular structure. However, part of the inhibition of these tyrosine kinase inhibitors is that they can cross-react with other inhibitors, and so it can have other impact as far as cells go. So Ayvakit or avapritinib was approved for indolent systemic mastocytosis in May of 2023, essentially. And really what they ended up doing is that they did a randomized trial of patients with indolent systemic mastocytosis and looked at them over a 24-week period and looked at symptom control and quality of life improvement. And essentially, there was 212 patients in this clinical study. 141 of them were on the avapritinib arm, and then 71 of them were in placebo. And the primary endpoint of this clinical trial was to look at quality improvement in symptom scores, and patients did have improvement. Most of these patients had an elevated tryptase, and then the interesting part of this is that obviously they had a KIT mutation, but which was found either through tissue biopsy or peripheral blood. And if you look as far as the patient population, the peripheral blood, about 23 of them didn't have detection of KIT in that even high sensitivity assay that's out there now. What was found is that essentially at the end of 24 weeks, these patients had significant improvement, or they had about 15-point improvement in total symptom score. But your placebo also had improvement, and I think it's just because patients are on best practices as far as therapy goes. And then once they were rolled over, the placebo was rolled over into taking avapritinib, they kind of met the avapritinib original group as far as the quality improvement. Most of these patients had an improvement in their tryptase. It significantly came down as far as the level went, but we don't really know if the level of tryptase correlates with regards to symptoms in general. So like if someone has a tryptase of 100, do they have more symptoms versus someone who has a tryptase of like 20? We don't really know that. However, it did come down, and so did the mutation improve by 50%. This drug does have side effects, and just like every other drug that we utilize, but at the lower doses is much, much better tolerated, but it can contribute to peripheral edema, and that's really one of the things that we see in clinic. As far as other highly selective KIT inhibitors coming out to the market is its sister bezuclastinib, who is in clinical trial currently as we speak, which could potentially be another target for indolent systemic mastocytosis. And it's a drug that is very similar to avapritinib that's already approved, with the caveat that it doesn't have as much of stimulation of other receptors, and as far as like the PDGFR, alpha and beta and so forth, and doesn't cross blood-brain barrier. So in general, mast cells can do a lot, and they're really an important part of our innate immune system. As you can see, they're involved in every single pretty much organ that we talk about, and essentially they have a physiological role to be there. However, when that goes haywire, that causes for patients to have significant symptoms and really have impairment of quality of life. And up to this, last few months, it's been really just management of symptoms with, antihistamines, anti-leukotriene inhibitors. But now we're kind of going down the pathway of utilizing agents that are much, much more targeted, and targeting the actual mutation in the hopes that they can provide a global symptom improvement, instead of hitting each individual organ system. And so the main things that I think are also important is that these patients are at risk for osteoporosis, and so they should be further monitored or frequently monitored for osteoporosis potentially, and DEXA scan. And also if they come in with back pain, you really have to think about maybe if they have a fracture, because they are at increased risk of those vertebral fractures, and then also peptic ulcer disease. So any questions?
Great talk, Farnaz.
Thank you. Any questions, anybody? Sorry, I can't
There's
see.
one in the chat. How often do you see asymptomatic people?
So actually, I do have about 2 patients that have significant urticaria pigmentosa and actually have a KIT mutation, but don't have a lot of symptoms. So it does happen, right? And I think that you should treat the patient, not necessarily their disease. Like I said, this is a disease that there is a risk for it to become into an aggressive form. And so that's really the monitoring of it that I would do for a patient. However, oftentimes, if they have some of those things, they're usually symptomatic. And I think that the pertinence of the new therapeutics really becomes into play for patients who are symptomatic and who are on so many different medications to help maintain them and still have a poor quality of life. To answer your question, there are patients that can be asymptomatic.
And one more from chat before Dr. O'Brien. Do patients with mastocytosis treated with c-KIT inhibitor develop resistance? If so, do you then change the inhibitors?
So this is a great question. So actually, when we talk about resistance, it's really with regards to oncological disease states where they have a mutation and it shifts. And so this it's not necessarily seen in indolent systemic mastocytosis. However, that's not to say that, as, we put more patients on this doesn't develop later on. But with regards to tyrosine kinases in general, when they develop resistance, it's more in the oncological world. And this is sort of a different avenue of hitting it from the immunological world.
Dr. O'Brien, do you want to take the mic?
Sure. Has anybody studied how many IBS patients or unexplained headache patients have mastocytosis? Because you're scaring me based on the patients I see.
This is not to mean to scare you. I think that the reason I put those 3 patients is because they're so common, right? You see patients like that all the time, and but they're really symptomatic. And I think that that's really the point, is that when patients say something to us, there is pathology. Just because we don't understand it, it doesn't mean that it doesn't exist for them. And this is just showing you how mast cells in general are so much part of the physiology of what we do on a day-to-day basis. This does not mean that like every IBS patient should get, a c-Kit, analysis and, CD117 staining or CD25 staining. I think the pathologist would hate us. But I do think that if a patient is symptomatic and doesn't respond to conventional therapies, then this would be something that should be communicated with your GI colleague as to consider.
Thank you for a great talk.
Of course.
Dr. Casale?
Hi, Farnaz, great talk. Theoretical question, do you think there would be a preference in regards to treatment using the tyrosine kinase inhibitors versus c-Kit or BTK inhibitors?
I think that the BTK, the other therapeutics have maybe less of a scary component to it, in the setting that, obviously, so there's this concept of resistance, right? But like, we don't really know that this is going to happen in treating patients with indolent systemic mastocytosis, because I don't think it's really been looked at long enough. But I really don't think that's going to be an issue. The issue with some of these tyrosine kinase inhibitors is that you're hitting other protein kinases. And so does that cause for downstream impact and side effect of drug? And obviously, that's the concern. Now, as these drugs become cleaner and more targeted, I think it's going to be hard to say what's going to work better, or this is better versus another type of thing. I think it's exciting that we have so many therapeutic options coming down the pipeline.
Dr. Cannella, did you have a question?
I did. I'm sorry. I just got somebody came to my office door. This was an awesome talk, especially from an immunology background that I have with infectious disease. A little different, but my question has to do with regards to mastocytosis and looking at the microbiome.
Yeah.
How is this right? Because this is again, like I was telling the fellows yesterday in my talk about non-tuberculous mycobacteria. Again, it's this interaction between the microbiome, being modified, the immune cells that are local that get changed, and then the disease state changes. So I want to know if you, again, it's like Hamlet's undiscovered country, right? That's what he famously said, right? And so, so what do you? I'd like to know what you think about that, and how that kind of could play into, into this. A colleague of mine studies this exact topic at Tulane. Dr. Sarah Glover, that a lot of her research is in this mastocytosis and GI disease. And so I wanted to see what you thought, and just to get your opinion. Thank you again. Great talk.
Thank you. So I mean, honestly, I think that I think microbiome in the GI tract, and actually even within the oral mucosa, is something that is, or even in sinuses, is something that really needs to be further evaluated. Because if you look at this is just kind of like what we know now, right? We don't even know all of the picture, but if you just even look at the receptors on the mast cells, you have TLRs, right? You have TLRs that are there. You have these complement receptors that are there. And I think that a shift in the biome of your gut or in your oral mucosa is going to be something that might activate these guys differently, right? I also feel that even a change in pH of your stomach can cause for a different activation of these guys. So it just shows you the complexity of the immune system and how much it plays a role in disease overall. And it's not just, one thing, and unfortunately, I think that as we fortunately, or I guess unfortunately, as we kind of navigate this world of biologics and targeted therapies and so forth, we understand more and more about what all of these different things are doing and contributing. But I think that we also have an avenue of a lot more to look at. And I do think that, just thinking about the microbiome is a big deal. Oftentimes, microbiome is looked at with regards to humoral immunity. I personally feel that microbiome is a huge component with regards to innate immunity. And I don't think that that is as much focused on within the microbiome realm, at least from, the perspectives that I see it as.
No, I agree. I think that it's especially with innate T cells, like INKTs, gamma deltas, mates, all that is, that it's almost like having a boxing partner and you're sparring with them. Once that changes, the boxer kind of gets bored and lazy. That's what my take is on it, especially from, again, more of an infection view. Again, great talk. And this shows to all the junior physicians out there, step one stuff does come back to bite you. And it's going to, moving forward in the science realm, step one stuff is important. So please remember that.
Right.
One more question from chat. How long is your wait list to get in to see you for evaluation for possible mast cell disorders?
So honestly, like my wait lists, I think our next availability is in January of 25, so it's a year. But I think that honestly, if you have a patient that you're really concerned about or you're worried about, please just email me or text me. We usually get them in within the next week. I love seeing patients, so I'm happy to see patients all the time. This is, education, patient care is my passion. Anything else?
I think that was it.
All right, great. Thanks, guys. Have a great afternoon.